so much, Hanya, and Lat 19 for this space. I've been following Lat 19 since its inception in 2020. I used to work at Duke University, so it's come full circle that I am actually now on the board of Latin 19. Um, I have spent my career in research, in preclinical research, and then clinical research. I've worked in industry. I've worked in the hospital system at Atrium Health in Charlotte, at the Cannon Research Center, and at Duke University at CTSI doing community engaged research. And I now do contract work, consulting work with organizations that are genuine about working with communities that have been left underrepresented, have not been represented in clinical research, and how can we go to those communities with the information in a way that they can understand and ask questions about it. It's very important that we listen to what the community has to say, answer their questions, and I always say we have to repeat it as many times because clinical research, to me, who's been in it my whole career, is something I understand, but it's not something that everybody should understand. It's like when I go to the mechanic and I get told that my car needs X, Y, and Z. I don't know what that means because that's not my wheelhouse. So I've been working on this project with NCCHCA since 2023, since it started. And it's a project that I believe in, and we've done amazing work with it. And Korrey will present about some of the great work we've been doing. Korrey's been with NCCHCA for a year now, and he is phenomenal, awesome, has great work ethics, and is really vested in making sure that we achieve what I hope I see in my lifetime. So with that said, I will go to the next slide. So in 2023, the FDA Office of Minority Health and Health Equity launched this REACH project, right? Because they saw the need for rural communities and racial and ethnic minority populations that are underrepresented in clinical research, and the fact and all the barriers that they're facing, and how are we going to approach that? It's very important that we face these challenges and we try to help our communities because these challenges will perpetuate with health inequities. And on the right, you will see in 2020, the FDA had this graph of clinical trial representation. And you can see that the Hispanic population and the African American populations were underrepresented. We're hoping that soon we will have updated numbers, but this is what we have from the 2020 data. Next slide. So, like I said, keep going, Korrey. There's, one more. Just said it one more time. So the FDA Office of Minority Health, well, sorry, go back. It for some reason, what the problem is, right? What is the problem? The problem is that, again, we don't have enough representation of communities that are not being represented, not because they don't want to participate, but a lot of times because they haven't been asked to participate or it hasn't been explained, right? What is clinical research? How will it benefit you? Why is representation important? So this FDA REACH, which stands for Racial and Ethnic Minority Acceleration Consortium for Health Equity, there's 6 groups. And Dr. Becca Hayes presented to Latin 19 maybe 2 years ago about the project. And we're one of the 6 groups based in North Carolina. There's a group representing HBCUs. There's a group representing the LGBTQ plus community. There's a group representing Hawaii rural areas, a group representing Puerto Rico and mental health issues there. There's a group representing tribal communities, and then us. So those are the 6 groups. Next slide. So why was this consortium set up, right? It's to hide in our project, our specific project here in North Carolina, who Dr. Becca Hayes is the principal investigator for. We are looking at rural communities. We're looking at the relationship between the federally qualified healthcare centers, that what the relationship is with these communities, and how the trust that community health workers have with patients. And one of the things that I always say is that, and I've said this, with Honey Estrada and the North Carolina Community Health Worker Association, that community health workers are the secret sauce to a lot of the work that we need to get done in our communities, because they already have the trust from the community members, and they know culturally how to work with our communities, how to get those resources to the community. So it's very important that we work with community health workers, especially if we're trying to increase the representation of minority populations in clinical research. And then the other thing that we're doing with our project is also to make sure that safety net providers, so providers, not just at federally qualified healthcare centers, but at your public health departments, at your free and charitable clinics, are aware and know what to say to their patients when a patient asks them if there is clinical research. But so what we're trying to do is just scratch the surface at this point and let people know about the opportunities of clinical research. Next slide. And Korrey, jump in if I'm forgetting to say anything.
Yes, ma'am.
So for our specific project here in North Carolina through the North Carolina Community Health Center Association, we had 3 aims. The first aim was to develop an admin core. And this is people from our community who are representatives of the community, who can have that voice at the table for the communities that we were working with. And what I thought was beautiful, and I always tell Dr. Hayes that I commend her for doing this, is that she put in the grant application that we were going to compensate the admin core participants for their representation, for bringing us this feedback. And one of the things that I think is great about this, our admin core, is that we actually listen to them and we take their feedback, because they know their communities better than we do. And these were representatives from throughout North Carolina. And then the second thing that we met once a month, by the way, the admin core, we met once a month via Zoom. Focus groups and surveys was the next aim. We did focus groups first in English and in Spanish with community members, with community health workers, and then we did focus groups only in English with providers. And then most recently, and Korrey will speak more about the focus group data and the surveys, we are still doing surveys, and the surveys have also been done in English and in Spanish, in person and online, with community members, with community health workers, and then with safety net providers in English only. And then our third aim was developing a curriculum, which we have just launched. We launched last week during Community Health Worker Week, Appreciation Week. It's a curriculum. It's a 2-hour curriculum, free, in English only at this time. We're trying to seek additional funding to do it in Spanish. Our original goal was to have it done in English and in Spanish at the same time, but due to everybody has seen cuts, right? We were only able to do it in English. And again, it's a 2-hour curriculum, and Korrey will speak a little bit more about it. But it's, again, scratching the surface about what is clinical research. And this is for community health workers to be able to talk to their communities about what clinical research is. So, yeah, aim one. And some of you might recognize Ivan Almonte. He was part of our admin corps. He's right there in our picture. That's Dr. Hayes, Korrey, myself, and Ivan when we went to the FDA back sometime in was it this year, Korrey? Yeah.
No, this year.
Yeah. Okay.
Yes,
And
ma'am.
then yeah. And then on the bottom, you'll see Dr. Robert Califf, right there in the middle. We had a meeting about the LGBTQ plus community and how to work with them in also, how to the wording in informed consent in clinical research, how to make people feel more inclusive, right? Having that empathy, the caring, all of that I know is something that I'm very passionate about, making sure that people feel comfortable enough to ask us questions, to just feel comfortable so that it could be a good experience for everyone. So that was our admin core. We met for 2 years. Our last meeting was in June of this year. So, and next slide. All right, so now I'll leave it to Korrey. And Korrey, I would love for you to do a little introduction about yourself.
Mhm.
And then please feel free, like I said, Hania said, to put in the chat any questions you have, and we would love questions at the end as well. Thank you.
For sure. Thank you for kicking things off, Perla. Good afternoon, everybody. I hope you're having a great day. My name is Korrey Monroe. I'm the Research Program Manager at the North Carolina Community Health Center Association. As Perla mentioned, I just came up on my first year being here, and it's been nothing short of great. A little bit about NCCHCA. We are the state of North Carolina's primary care association, providing care to 750,000 patients annually through our 43 federally qualified health centers and health center lookalikes in North Carolina. And 60% of our population of patients are minorities. So we are really focused on providing culturally competent and equitable healthcare across the board. A little bit more about myself. Prior to joining NCCHCA, I received my Master's of Public Health from the University of Michigan, School of Public Health and Occupational and Environmental Epidemiology. And while I was in Michigan, I was able to act as a research assistant as well as a clinical trial research coordinator for multiple clinical trials and research studies located in southeastern Michigan. So the things that I was able to accomplish in Michigan, I've been able to transfer those skills into this work, and it's just been great to engage with our communities across the board. So first, we'll start off with our surveys. We conducted 7 focus groups. I'm sorry, with our focus groups. We started with 7 focus groups with 37 participants in total. And the objectives of our focus groups were to, 1, explore the attitudes and willingness of the 3 populations of community members, which are patients, community health workers, and safety net providers regarding clinical research, to identify the barriers and challenges that they experience in engaging with clinical research, and then also to develop practical solutions that will propose actionable strategies to enhance engagement and participation, specifically amongst community health workers and safety net providers. But we also explored this with the community members as well. So as I mentioned, we had 7 focus groups. 4 of those were in English, 3 of those were in Spanish. As Perla mentioned, with community members and community health workers, we were able to host those in Spanish, where Perla led those focus groups. She also led the English focus groups as well, except for the safety net provider focus group, which was led by Dr. Hayes. So here we have a breakdown of our focus groups. And as you can see, we did have a huge focus on minority populations, specifically Black and Hispanic populations at the beginning of this project before the changes with the current administration. And one thing I like to bring notice here is at the bottom. Clinical trial participation by group. In each of these groups, you see a noticeable gap between those who have participated and those who had not participated, which emphasizes the need for more information and more research to be done on this issue of clinical trial participation so that we can have more equitable and understandable information on how medicines impact the bodies, or not even medicines alone, but interventions as well, on how they impact different populations. So from our community member focus group, we'll start off with the willingness to engage. We learned that our community members are interested in participating in research, but they're cautious due to those past harms and injustices that have been experienced by multiple generations over the past decades. As listed here in barriers, to note, Tuskegee was one of the most prominent ones mentioned throughout our focus groups, but also bringing notice to other ones such as the Puerto Rico birth control trials that happened in the 1950s. And another barrier that came up throughout the focus group that was persistent was medical distrust, as well as language barriers, and not being able to really understand the material that is being provided to them, if it is. Throughout our focus groups, we also learned that a lot of people had no idea what a clinical trial was, and that they had no opportunities to even learn or join a clinical trial. So we've included a quote here from one of our community member participants. "Am I being a guinea pig because you want to try it on me?" And that was something that was consistent throughout our focus groups. People feel like they're being experimented on instead of being cared for. And with these focus groups, our goal is to really bring attention to these issues so that we can adjust and address them in the correct way. So through our community member focus group, we were able to identify the support that was needed for engagement through their responses. This included culturally competent and bilingual staffing, making sure that those who are engaging with our populations understand who they are and meet them where they are at. Also, clear and plain explanations. A lot of people have varying academic levels and understanding as far as literacy. When it comes to receiving information, we need clear and plain explanations that everyone is able to understand. Also, accessible materials. This goes hand in hand with the language barriers. We need accessible information that everyone can understand in a way that they will understand it. This is not only limited to language, but also in other areas of literacy, such as tech or just literacy in general. And also discussions with your trusted physicians. Through our focus groups, community members express that they trust their providers. And if their providers are the one that is engaging with them when it comes to providing this information on clinical trials, we may see an increase in engagement and participation in clinical trials. And then just emphasizing this need for clear and accessible information, we've included this quote here: "They need to break it down. Do it on a level that the people understand." Now, for community health workers, their willingness to engage in clinical trials wasn't from a participant perspective, but more of a staffing perspective or assistant perspective. So for them to engage in clinical trials, they're open to bridging the gap between the community and researchers if trust, and only if trust and respect are established. And this emphasizes the role of the community health worker having their unique positioning in the community to not only relate with their populations, but to understand them. So some barriers that community health workers experience are limited access and awareness of information, not knowing how to access information, and really understanding what clinical trials are to then go into their communities and educate. Because throughout our focus groups, community health work is really big on understanding and knowing the information prior to going and engaging with their communities, just to make sure that they were providing the correct information only. The second barrier that we learned about was the lack of community awareness of clinical research. Community health workers acknowledge that due to their communities having unique standings as far as multiple factors, whether that be literacy, whether that be rurality, there may be this gap in understanding of what clinical trials are. And then lastly, the risk of their reputation and trust being lost with their communities. As I mentioned earlier, community health workers have a unique standing in their communities. They bridge healthcare and community. And if they were able, or if they were to engage with clinical trials or spreading clinical information and some misfortune happens, then there's a huge risk for their reputation being on the line and losing that bridge that they have with their communities. So a quote that we've included here is that I would not put my reputation on the line if due diligence has not been done. That's not just, them having an understanding of what clinical trials are, but also the research companies, whether that be academic university coming to do research, a clinical research organization, there needs to be due diligence being done, such as coming into the community, completing a needs assessment, learning about the social and structural barriers in their communities to make sure that we're providing the best care possible and establishing the respect, not from the community for the researchers, but for the researchers for the community. And for community health workers to engage in clinical trials, some things that were identified were formal training in various languages, which actually encouraged our creation of our curriculum, the recognition of community health workers as research partners and resources, leveraging their understanding, leveraging their relationships to build the relationship between community and researchers, and then also building upon that, the inclusion in study design, outreach, and educational efforts. I'll say it again, the community health workers' unique understanding provides infinite value to those concepts of study design, knowing how to recruit our populations, knowing information to provide, and also the outreach strategies, not only just going into the communities, but creating that long-standing relationship with the community and not being a helicopter researcher, coming in, getting what you need, and leaving the community high and dry. So a quote that we have here is that we bridge those gaps together. It really speaks to the role of community health workers. Safety net providers, as Perla mentioned, these are the providers of the primary healthcare providers of safety net organizations. And same as community health workers, for our safety net providers, we wanted to learn more about their willingness to engage and actually leading clinical trials in their research centers or in their communities. So they're in support of research, but they are also cautious about the burdens on patients and clinics potentially if things were to go wrong or due diligence has not been done. So their barriers include researchers having this lack of understanding of patient and community realities, coming in with unreal expectations as far as engagement, persistent participation throughout the trials, also concerns about protecting federally qualified health center patients in general. Federally qualified health center patients are usually uninsured or have various income levels because federally qualified health centers are required to provide care regardless of those statuses, which makes them extra vulnerable. And then another barrier was little to no formal training provided for safety net providers to actually engage in clinical trials. And then also building upon that, their lack of time due to the heavy workload. On average, primary care providers will see 20 to 25 patients in a day, which only emphasizes the need or the issue of this time constraint. So a quote that we've included here is that they were not tuned into the reality of what day-to-day life is like for our patients. Now, the support needed for engagement for safety net providers includes a seat at the table in study design. Similarly to the community health workers, they also have an understanding of their community and their patients, which will only pay dividends into creating more equitable and accessible care as far as it comes to engaging in clinical trials. Also, clinical trials in familiar and proximal spaces in the community to meet the people where they are in doing this, we're actually going to avoid the barriers or address the barriers that will only increase care or access to care for these populations, whether that be bringing a clinical trial to the FQHC in itself, or just at a local space that people feel welcome and they know, you know. And lastly, accessible formal clinical trial training integrated into their workflows, whether that be conferences, workshops, or continuing education. It provides a seamless path for clinical trial education or information to be spread to these populations. And a quote that we've included here is that getting a seat at the table or some input would be beneficial, not only to the safety net providers, but also to the research. So with us doing the focus groups first, we were able to take those lessons and those things that we identified through the focus groups and apply them to our surveys. And this was a very inclusive process. We worked in collaboration with our administrative core to create the clinical trial surveys for all three groups. It wasn't just for community members or community health workers. Our admin core was very diverse with people from various backgrounds. We had some providers there in itself. So being able to input their value and their perspectives really paid dividends as well in the creation of these clinical trial surveys. So the objective of our surveys were, one, to understand the experience and awareness levels of community members, community health workers, and safety net providers regarding clinical trials. Staying on those three key populations throughout this project was our main focus. To raise awareness about the challenges that prevent community members, community health workers, and safety net providers from participating in clinical trials. And then lastly, to identify the support needed to enhance participation in clinical trials for all three of those groups. And there are some consistent themes throughout this. We wanted to quantify our findings from the focus groups to then have statistical evidence of these things, which will only strengthen our claim in our future efforts. So as Perla mentioned, community member and community health worker surveys were deployed in person as well as online for community health workers. We had over 10 surveying sessions in various locations across North Carolina. With our three partnering FQHCs, Charlotte Community Health Clinic, Med North Health Center, and Rural Health Group, we were able to do various sessions. And then we also attended community events as well as some other safety net organizations to complete surveys. And for community health workers, we were actually fortunate to go down to the North Carolina Community Health Worker Association Summit and complete surveys there, which was very fun. So a little bit about the demographics of our survey participants. We had a majority of Black or African American as well as Hispanic Latino participants among community members and community health workers. And then with safety net providers, it was more broad in the variance as far as those who, the different racial backgrounds. And for our community health workers, our goal was to survey 157 participants. Community health worker and safety net provider surveys are still open. We are looking to survey 134 community health workers and 144 safety net providers. So now we'll go group by group on some of our key survey findings. For community health workers, nearly half of the population lacked awareness of clinical trials, and over 80% of the sample had not participated in a clinical trial ever, which only emphasizes the need for more education and more opportunities for our communities to engage even. And then 89.2%, which is the majority of the population again, also believe that clinical trials could contribute to improving health, solidifying our findings in our focus groups. Willingness to engage in clinical trials, over half of the participants would consider participating in a clinical trial if their primary care provider invited them, really emphasizing the need to go through trusted individuals to spread information. And harping on that, also in health centers, so within federally qualified health centers, health clinics, the most trusted sources of information are doctors, nurses, and community health workers. And then outside of the community health centers still led the rankings in being the most trusted sources of information, followed by friends and family. And the majority of participants would like to receive their information on clinical trials in person. And this emphasizes that need of in-person engagement, whether that's to continue on those conversations or to ask questions then and there, to get a really clear understanding of clinical trials and clinical research in general. So community health worker findings, I'm only going to hit on a few of these here. Over half of community health workers were at least familiar with clinical trials, and the majority believe that clinical trials can contribute to improving health. As far as their barriers to engagement and actually being that bridge between community and clinical trials, time commitment, lack of knowledge, and distrust of researchers were the highest rated factors that will prevent them from assisting in a clinical trial. And then as far as their willingness to engage, 72.3% would consider assisting in a clinical trial if their employer invited them. So once again, going through those trusted resources, those trusted individuals or organizations. And also community health workers are willing to share information with their communities while also attending information sessions and trainings with their community members. So really acting as that bridge, even there throughout the process, whether that be with recruitment, whether that be with just spreading the word about clinical research, they're willing to be there and present to support their communities. Now, one thing we found shocking was that under half of the community health workers felt comfortable with recruiting and enrolling people from their communities in clinical trials, as well as educating them. And there is a need to continue that research to understand what is impacting them or impacting their comfortability to engage with their communities. As far as community health workers receiving information, they would prefer to receive the information in a more hybrid setting. And the highest ranked format to receive that information was actually for an in-person conference. And their most trusted sources to receive information on clinical trials were healthcare professionals, local and state health departments, as well as academic institutions. For our safety net providers, as far as integrating research into health centers, the majority of providers expressed that it was important for the clinical trials that are to be conducted at their health center directly benefits their patient population. And that's something that we heard directly from patients as well through the focus groups. Most providers did not know their health center's interest in conducting clinical trials, regardless of their standing, as well as over 2/3 of providers expressed interest in fulfilling a role in a clinical trial, whether that be a principal investigator, a co-principal investigator, or a site coordinator. Building upon that, the barriers to engagement for safety net providers in actually leading a clinical trial includes a lack of time and funding, and only 1/5 of the providers felt confident in their ability to conduct the trial, emphasizing the need for training as well as education to be provided for them as well. To address those barriers of time, we saw that protected time, dedicated research staff, and on-site support from research organizations were seen to be the most helpful. And to address the issue of funding, we saw that simplified application processes and grant writing assistance were seen to be the most helpful as well. Now, the support needed to actually engage in clinical trials for safety net providers, it included that over half of the providers would be interested in participating in a clinical trial training program that would help them lead in clinical trial efforts, which was really great to see. It kind of gives us more motivation to pursue that effort in creating something like a curriculum for safety net providers to bring clinical research to our communities and to create a more accessible landscape for the research as well. And then for providers, in-person workshops are recognized to be the most beneficial for learning about clinical trials amongst the providers, as well as online self-paced learning module like a curriculum. Some key takeaways from our AIM2, so both the focus groups and the surveys. One, we need more awareness across the board in all groups on clinical trials. And after we have that established, we can create partnerships, build the trust, and educate our communities as one to create a more equitable landscape as well. Community health workers can effectively share clinical trial information and advocate for their communities. Once again, their unique standing makes them invaluable to clinical trial engagement across the board, whether that be in the communities, study design, as well as engagement in clinical trials. Encouraging decentralized clinical trials, so those familiar sites that aren't technically a clinical trial site, a familiar space will help reach more populations and potentially reduce the barriers to participation, whether that be in the community or very close to the community. We can address the issue of transportation, which is seen in research to be one of the most prominent barriers to participation. Community health workers and safety net providers are interested in training and education for clinical trials, solidifying the need for education and training programs to integrate them into research. And then lastly, as emphasized from the focus groups to here, culturally relevant materials, information, and trusted individuals are needed to engage with these populations effectively or efficiently. These people understand their populations. With culturally relevant materials, people are then able to better understand the information that's being provided, and it'll just be better for us in general as we move forward to engaging with underrepresented populations. So now aim 3, talking a little bit about our curriculum. We are, well, as Perla mentioned, we launched the curriculum last week. The curriculum is titled Clinical Trials 101, an advocacy-focused curriculum for community health workers. And the purpose of this curriculum is to equip community health workers with the knowledge and skills to help their communities make informed decisions about their health and support them through clinical trial engagement. A little bit more about our curriculum. It takes 2 hours to complete. It's totally self-paced. You'll get 90 days to complete it. We're hosting it on the Canvas Learning Management System platform. It's an online platform. You will need a device to access it. And our curriculum is unique because we use interactive elements throughout to make the curriculum more engaging. We want people to enjoy the learning process on clinical trials and not to just get bored standing at the computer. We've all been there. So we've included different multimedia elements, whether that's recall activities or case studies that we featured as well, that both Perla and I recorded with our collaborator at Equality Sciences. And let me see, I'm sorry about that. Building upon our assessments, for our evaluation to make sure that our curriculum is being effective in our goal to educate our communities, community health workers, we've included pre-assessments as well as post-assessments and confidence surveys to test both before and after completing the curriculum. And just some topics that are covered in our curriculum include an introduction to clinical trials, providing that foundational framework or foundational understanding of what clinical research and clinical trials are, understanding the drug development process, barriers to participation, creating more awareness about what's hindering our community's participation to clinical research and how we can all address those together. The importance of participating in clinical trials for all populations, potential questions and concerns from communities that community health workers may receive to better prepare them, to give them examples of what to expect. And then also, as I mentioned, the case studies, seeing some examples of what they may experience live in a video, which was very fun to make. So if you're interested in registering for the curriculum or just want to stay up to date on our work that we're doing, you can scan this QR code right here on the right, and it'll take you to a Qualtrics form online that you can complete, and then you'll be listening to our registry depending on what you select. If you want to take part in the curriculum, we will provide you with your login for the curriculum, and you'll receive that within 2 business days. So that will conclude our presentation today. I want to say thank you for allowing me your space to provide, to share this work with you all, as well as thank you to Perla for coordinating this and setting this up. I've included our contact information here and open to questions.